Good day, everyone. My name is Dr. ARAVINDAKSHAN. I am a junior resident at the Department of Radiodiagnosis at MMIMS Ambala. I will be presenting my paper on the role of cross-sectional imaging in the diagnosis and management of groove pancreatitis. Groove pancreatitis, also termed paraduodenal pancreatitis or cystic dystrophy of the duodenal wall, is a distinct variant of chronic pancreatitis localized to the pancreaticoduodenal groove. Groove pancreatitis primarily affects middle-aged men with alcohol abuse or history of smoking. Clinically, it presents with epigastric pain, vomiting, and features of gastric outlet obstruction. The condition is often misdiagnosed as pancreatic head carcinoma, resulting in unnecessary resections. Cross-sectional imaging such as MRI and CT is preferred for identifying characteristic features such as groove masses, duodenal cysts, and fibrotic delayed enhancement. This study retrospectively reviews 60 pancreatitis cases, of which 10 were diagnosed as groove pancreatitis, and to highlight cross-sectional features, treatment approaches, and clinical outcomes. 60 consecutive cases of pancreatitis were retrospectively analyzed and evaluated with CT-MR. Amongst these 10 cases were diagnosed as groove pancreatitis based on characteristic cross-sectional findings and clinical correlation. For each groove pancreatitis case, demographic information such as age, sex, alcohol, and smoking history was collected. Features assessed included groove mass, duodenal wall cysts, duodenal wall thickening, main pancreatic duct dilatation, and delayed enhancement. Additional features such as smooth common bile duct tapering, absence of vascular invasion, and lack of lymphadenopathy were also noted. Management strategies were categorized as conservative, endoscopic, or surgical. Outcomes were classified as clinical improvement, stable disease, recurrence, or benign confirmation post-surgery. Descriptive statistics and graphical charts were prepared for groove pancreatitis subset. Out of the 60 pancreatitis cases, 28 were acute, 15 were chronic, 7 were autoimmune, and 10 were groove pancreatitis. This analysis focuses on the 10 groove pancreatitis cases. The mean age of patients with groove pancreatitis was 48 years. The male to female ratio was 8:2. Alcohol consumption was present in 7 patients. Smoking history was reported in 4. All patients were presented with epigastric pain and several reported vomiting or gastric outlet obstruction. MR and CT findings demonstrated a groove mass in 9 out of 10 patients. Duodenal wall cysts were identified in 8 patients. Duodenal wall thickening was present in 6. MPD dilatation was seen in 2 patients, and delayed enhancement consistent with fibrosis was noted in 3 patients. Smooth distal CBD narrowing was documented in 3 patients, and restricted diffusion as seen on MR was observed in 2 patients in the acute phase. No cases demonstrated vascular encasement or significant lymphadenopathy. These findings highlight groove mass and duodenal cysts as hallmark features of groove pancreatitis. This is an axial CCT image which demonstrates a hypodense soft tissue mass in the pancreaticoduodenal groove with associated cystic spaces, resulting in upstream MPD dilatation. This is a coronal CCT image which demonstrates the hypodense soft tissue in the pancreaticoduodenal groove with associated cystic spaces again. Initially, this was suspected to represent malignancy. This was found to be groove pancreatitis on surgery. These are axial T1 and T2 weighted images on MR. These show sheet-like groove masses with cystic spaces. So 5 patients were managed conservatively with medical therapy, alcohol abstinence, and enzyme supplementation. 3 patients underwent surgical intervention, most commonly pancreaticoduodenectomy. 1 patient was treated with endoscopic drainage, and 1 patient initially managed conservatively experienced relapse, further requiring evaluation. Among the 60 pancreatitis cases reviewed, groove pancreatitis represented 16% of the cohort. Although less common than acute or chronic pancreatitis, it posed the greatest diagnostic challenge due to its close mimicry of pancreatic head carcinoma. MRI and CT consistently demonstrated groove mass and duodenal cysts as the most frequent features. Duodenal wall thickening and fibrosis with delayed enhancement were also common. Additional findings included smooth CBD tapering and restricted diffusion in acute cases. The absence of vascular invasion and lymphadenopathy further supported the diagnosis of groove pancreatitis over carcinoma. The differential diagnosis with pancreatic Adenocarcinoma is crucial. Features favoring groove pancreatitis include smooth, long CVD stricture versus abrupt cutoff, presence of duodenal cysts, delayed fibrotic enhancement, and lack of vascular encasement. These imaging biomarkers are central in guiding clinicians towards conservative or endoscopic therapy. Surgery should be reserved for obstruction or diagnostic uncertainty. Thank you.